Welcome to Med Study Pro. In this guide, we'll break down the types of shock, explain key hemodynamic patterns, and walk through real clinical strategies to manage them effectively. Whether you're at the bedside or studying for boards, this is the shock review you need. Let's get started. Shock is not just about low blood pressure. It's about the inability to deliver oxygen to the tissues. That leads to anaerobic metabolism, lactic acidosis, and eventually multi-organ failure. One of the most important concepts to remember is that hypotension is a late sign. You need to assess perfusion by looking at mental status, urine output, and even skin changes early on. These are the foundations of understanding any type of shock. Central venous pressure, or CVP, gives you a sense of preload and right-sided heart filling. Pulmonary artery occlusion pressure, PAOP, or wedge pressure, reflects left-sided preload. Cardiac output and cardiac index tells us how well the heart is pumping, while systemic vascular resistance, SVR, shows afterload. And finally, SVO2 gives you insight into oxygen delivery versus consumption. Watch for trends, not just single values. While we often fixate on mean arterial pressure, MAP, we can't forget the rest. Urine output is a great indicator of renal perfusion and overall volume status. Capillary refill is especially useful in pediatrics and resource-limited settings. Rising lactate suggests worsening shock or impaired clearance. SVO2, especially when placed in the SVC or pulmonary artery, helps in assessing whether tissues are extracting too much oxygen, which is especially relevant in cardiogenic and septic shock. Here's your anchor. 4 primary categories: hypovolemic from volume loss, cardiogenic from pump failure, distributive due to vasodilation, and obstructive from external barriers. Each one has a different cause, profile, and treatment approach. If you know this framework, you can categorize most real-world cases quickly. Classic hypovolemic shock shows up in trauma and GI bleeds, but also in patients with severe dehydration or burns. You'll often see flat neck veins, cool extremities, and narrow pulse pressure. Fluids, usually isotonic crystalloids, are the first step. If there's hemorrhage, replace with blood. Don't forget to identify and stop the source of volume loss. Think of this as pump failure. Most commonly, it's from a large myocardial infarction, but also in decompensated heart failure or myocarditis. These patients look sick. Cold extremities, low urine output, and sometimes altered mental status. You'll often see pulmonary congestion and elevated jugular venous distension, or JVD. Start inotropes like dobutamine, but be cautious with fluids. Vasopressors like norepinephrine may be needed to maintain perfusion. If cardiac index doesn't improve, mechanical support may also be required. Sepsis is the most common cause here, but don't forget about neurogenic shock after spinal cord injury or anaphylaxis. In early septic shock, patients may have warm extremities and bounding pulses due to high cardiac output. The hallmark is low systemic vascular resistance. Fluids are key, but if hypotension persists after adequate fluid, start norepinephrine. Don't forget the source control: antibiotics, drainage, etc. This category is often under-recognized. Think pulmonary embolism, cardiac tamponade, and tension pneumothorax. These patients often have distended neck veins, pulsus paradoxus, or muffled heart sounds. You'll see high central venous pressure, but very poor forward flow. Treatment isn't vasopressors. It's relieving the obstruction. Thrombolytics for pulmonary embolism, pericardiocentesis for tamponade, and needle decompression for tension pneumothorax. This chart helps tie it all together. Don't just memorize, understand the logic. Hypovolemic and cardiogenic shock both present with low cardiac output, but preload is different. Distributive shock is unique with low systemic vascular resistance. Obstructive looks like cardiogenic hemodynamically, but with a mechanical cause. These patterns help guide your interventions. Always start with the ABCs: airway, breathing, and circulation. Oxygen, fluids, and monitoring come next. Norepinephrine is your go-to vasopressor for most shock states, but don't delay treating the root cause: antibiotics, cardiac support, or procedures. Continuous reassessment is essential. Don't treat a mean arterial pressure number. Treat perfusion. Match the pressor to the problem. In sepsis, use norepinephrine. Cardiogenic shock needs inotropes like dobutamine. Anaphylaxis, epinephrine is life-saving. Neurogenic shock often responds to phenylephrine. And in obstructive shock, pressors are only a bridge. Relief of the obstruction is definitive. A 65-year-old man presents with fever, altered mental status, and hypotension. Lactate is elevated. You give 30 mL per kilogram of fluids. Start norepinephrine for a MAP that continues to stay below 65 despite fluid resuscitation. And give broad-spectrum antibiotics for a suspected urinary tract infection. You monitor urine output and lactate. After 6 hours, both improve. This is timely sepsis management in action. To wrap up, shock can present subtly. Watch for early signs of poor perfusion. Fluids are first, except in cardiogenic cases. Know your hemodynamics and reassess constantly. SVO2, lactate, and urine output tell the story. And most important, don't delay treating the underlying cause. Want all of this in a printable, easy-to-review form? Check out our full study guides on Amazon from Critical Care Common Conditions and Critical Care Hemodynamic Monitoring. Links are in the description. For more content, don't forget to like and subscribe. We'll see you next time.